Very good morning, everybody, and we'd love to get started if we may. Welcome to this session with Elaine Miller-Karras and myself. I'm going to be doing the first 15 minutes or so, and then Elaine will come on after me and do another 15 minutes. So we'll both be presenting our models, and then we'll be going into a few questions, and then we're going to have some questions around the table, so we get some table discussions and a bit of feedback as well, so that would be great. If you, just for the presentation part, you might want to sit so that you can just see the screens, because they'll be coming up, the models will be coming up on the screens, so that'll be fine. We're going to make sure that you have at least 30 minutes for discussion and questions and so on. Been asked to ask you to make sure your cell phones are off, partly because we're filming this session, so you don't want to be that person who is forever immortalized, patting at their pocket or their purse. And if you be kind enough, when you want to speak to the floor, if you be kind enough just to ask for a microphone, a mic will be brought to you. And then the Skull colleagues have asked you to fill in this little form which is in front of you. So let's get cracking. My name's Chris Underhill, and I'm the founder of this organization here. That's the last slide. So that was the end of the presentation. Let me just see how this goes. There we are. But that was quite off-putting, really, but this is now here. So I want to present the model for mental health and development to you. This model was developed in the year 2000 in Karnataka State, and it was developed by myself, and it was field tested by a gentleman called Naidu, D.M. Naidu, who is deceased now. He died a little while ago, but he put all the work into field testing it in India, and that's where we started to do it. Just to remind you what the issue is, some of you, I suspect, in the room already know what the issue is, but for those who don't, it's a very serious problem, and it's often a problem, I think, which is completely misunderstood or underestimated. And in that sense, we have the responsibility, I think, today, and whenever we make a presentation, to draw to your attention the kind of statistics that we're floating on the screen at the moment, and the kind of atrocities that people face on a daily basis in the field of mental health. I founded the organization in 2000, and the mission and vision are on the board there. The vision has always been important to me, that people with mental disorders throughout the world are satisfied and their basic rights are respected. We are, ladies and gentlemen, a long way from that halcyon goal, but it's really important for us to have this kind of value objective in front of us as we head into the next few years. When I started the organization in 2000, it felt a particularly lonely spot, and I'm very pleased to say that we have been joined by others as we move forward. And there are several people in the room who are now in command of organizations, which make this a slightly less lonely place. But it is still a pretty lonely place in respect of many other fields of endeavor. But I'm pleased to say that the people on the bottom there have definitely given us succor. The model in brief looks like this. I just wanted to summarize it for you, first of all. This is the model for mental health and development. It's based very substantially on my own background and that of Naidu and other people who have found themselves as activists working in this field, particularly in the late 90s, 2000s. It's purloined very substantially from agricultural and other development practices, and so we have definitely extended and expanded the reach well beyond the person-to-person work that you associate with patient-focused models of care. And what's very important here is that we work, it seems to me, with the resources that we have available, and that will become clear as I move you through. So as you can see, I'm going to start you at the top of the cycle there, capacity building, and just move you on. All the photos, by the way, have been taken by people at Basic Needs throughout the years, and in very many cases, the photos, and in fact in most cases, the photos have been discussed, and the people who are in the photos have often given their verbal permission to allow you to see the photos and to extend the advocacy which photography obviously brings. So capacity building here, it's about bringing people to a meeting. It's not about treatment at this stage, and the capacity, and what I'm most interested in is that we capacitate people with mental health problems, the mentally ill, that we bring them to the meeting and that they actually have an opportunity to speak about the issues that confront them, to complain about the problems that face them within the community itself, and ideally, in this kind of animated meeting, for the community itself to be aware, to understand of some of the pressures and problems that come upon us when we are mentally ill, living in the community, and also what affects our relatives and our immediate loved ones. And that's what really comes out of the capacity building process. So people, as they go through this process, it's more than a day, of course, but it starts with a full day. As they go through this kind of process, in the end, they get more confident to speak out and to say what they feel they want to say and to bring to the attention of the world, meaning the world that they live in, what they want to be able to convince us of and why they want change in their own lives. The conventional thoughts about mental illness is that it's about treatment, and clearly it's important that offers of treatment be made where it's possible and where it can work. Here you have a situation in Laos, very few psychiatrists in Laos. In fact, Dr. Chandravani Shulamani, who's the program director in Laos, is one of only 2 Laotian psychiatrists for a population of 5 million. So what she's done is she has trained normal doctors, that is to say hospital doctors, to take on the diagnostic duties. And so here you have a situation where a doctor who is trained in diagnosis is meeting a patient. The whole question of task shifting, in other words, people doing roles that normally they would not have been expected to do in the context of their qualification, is very substantial in the field of global mental health. And people often find themselves in a situation, for example, a community health volunteer, where they are doing work which perhaps in other countries where more qualifications exist and more qualified people exist, they might not do. There's an interesting side reference to this, which is that actually they often do the job very well. And so we have to, I think, on the back of the fact that task shifting is a necessary requirement, we have to, I think, give thought to the possibility that the community itself plays a highly important part in quotation marks, the treatment of people with mental health problems. The actual treatments themselves that are offered to patients can vary enormously within this kind of program because we work with a very wide range of patients. People with schizophrenia, right the way through to people who are suffering from relatively mild depression. And obviously treatments therefore differ between patients. And sometimes they're pharmaceutical, pharmacological, and sometimes they are person-to-person or in small group therapeutic environments. Cognitive behavior therapy would be an example. Moving on. This is my favorite bit of the model, the program, in that I feel that it's really important to offer people who are living often in great poverty, to offer them some opportunity to begin to make ends meet, to turn a penny. And people who are in the program and have been for some time, themselves often say that it was the livelihoods module of the program which first actually attracted them. Because after all, this being a circular model, people can enter the model in whichever place they wish to. And coming out of the capacity building module of the program, of the model, comes the opportunity to create groups, self-help groups. And self-help groups are then the right vehicle, it seems to me, for livelihoods to take place in. So this is what is, I think, important to me in many ways, offering people the opportunity to be able to create something for themselves, a small amount of income or contribution of food to the family. And as you can see by the people in the photograph, people feel confident when they can start to make a contribution, when they can actually make a contribution to their own families again. It makes a huge amount of difference. The organization over the years has, of course, been involved in a number of empirical research opportunities and studies, but the work that we're looking at here in the picture is essentially action research. It's where people with a mental health problem are coming together and where they are thinking about the program that they are part of itself, and they are beginning to think about a contribution that they can make to the actual progression of the model, but also the program itself. This is what Naidu used to call mid-course corrections. And so we used to be able to bring people together on a regular basis, meaning once every 6 to 9 months, so not frequent, but regular. And they used to be able to really think through how the program would develop. And this is a practice which they really enjoy. They take their time over. And of course, involvement of this kind basically means that people feel in control of the program, and especially in control if they see changes beginning to occur. Collaboration is where the partners themselves who are helping to run the program come together, form alliance, form coalition, and move forward as one. Give you a sense of the scale and impact of the work. I wanted to draw your attention to the flexibility of this particular model and the way in which it can be adapted for different contexts. So recently, Basic Needs US has been working with a group of American advisors, mental health and other advisors, to think about the way in which the organization can take the model and bring it into the United States, the first city being Detroit. And we've been working in Detroit now for a little while, thanks to the Robert Wood Johnson Foundation and Duke University's Innovations in Healthcare. And here you see, in a sense, a simplification of the model, and certainly a rationalization of it in relation to entry into a more complex or more crowded marketplace in the context of the United States. For those of you who are, design program nerds, this is the kind of information that you'll want, and we can certainly make sure that you have it. But this basically gives you a good sense of how the model was redeveloped and then replicated so as to be able to move the model into the United States. The key and important factors here, I think, to take note of are A, the support of the, in this case, the Wayne County Chief Executive of the Mental Health Authority there. The next thing is, of course, the NGO called Southwest Solutions, who are the actual actors who are putting the model into place and who have been trained to do so. And I spent 2 very enjoyable phases working with their staff, making sure they know the field skills and the actual active animation skills which make it possible for them to do. The next stop after that is probably going to be New Mexico. This is the advisory group who helped to put the model into the United States, a distinguished group of Americans working with colleagues from Kenya, Ghana, and elsewhere. So there we are, ladies and gents. That's the model for mental health and development. And I'm going to pass straight over to you, Elaine, so that you can knock them dead with your model.
Knock them dead.
There you go.
I don't really want to do that.
Thanks, ladies and gents. Questions we'll take at the end, okay?
Well, first of all, I want to thank Skoll for allowing Chris and I. We had this idea of doing this, and Skoll worked with us to put our presentation together. I'm Elaine Miller-Karas, and I'm the co-founder of the Trauma Resource Institute and the developer of what's very dear to my heart, which is called the Community Resiliency Model. And let's see, oh, I'm up now. So we also have, I want to tell you just right off, we have an app called iChill, which is only in English at this point, but it's really good for all of us. It's free. You can get it through the Droid store. And if you don't have a smartphone, which I would doubt that I would imagine everybody in this room has a smartphone, but we also have a .com iChill, because we found that some people didn't have smartphones, believe it or not, but they did have access to a computer or some way to get online, so we wanted to make it as accessible as possible. So I want to tell you a little bit about myself. I'm a licensed clinical social worker. I'm an old trauma therapist, and I'm 64 years old, and he's 68, so how many? 132 years between the two of us. So we have been around a lot. And I have had many different lives as a social worker, but one of the things that very much impacted me was being a teacher of family medicine, because I would co-attend with the medical faculty, and young interns and residents would bring us the cases of just having been into a room and talking to someone who was from the inner city of San Bernardino County, which is very impoverished and economically challenged. And people would come in and say, oh, my head hurts, my stomach hurts, I have this pain, maybe I have cancer. And then my job was to say, go back in there and find out what's happening in their life. And what do you think the answer was? Some kind of trauma. So there was a drive-by shooting. Their son was sent off to Iraq. There was domestic violence in their household. So when we looked at all the things that were coming into family medicine, there was such a high degree that was connected to highly stressful events and trauma. So this was many years ago. I started the Trauma Resource Institute in 2006. But in tandem with that, I had the opportunity and honor to go to Thailand after the horrible tsunami. And working there on the ground, boots on the ground, I could see that many of the cognitive-based models that we traditionally learn in Western psychotherapy were not very effective. But I was trained in a biological model. And then I thought, wow, if this could help people here in a very short period of time, what if there was a model that was more accessible, more affordable, and transportable, that we could teach to many people, that could expand the capacity of well-being, not only after a natural disaster, but also human-made disasters. And so that was the birth of the community resiliency model, really happened in Thailand. And since then, I've been to many of the I guess which we call the black swan events of the world. I've been to Nepal after the earthquake, Haiti after their earthquake, the Philippines after Typhoon Yolanda, many, many places on the globe, many more than that. But what we've seen when we go to many places, of course, there's the mental health challenges that people face that have diagnoses like schizophrenia. But when we talk about depression, we talk about anxiety, what we started to learn was that we have another portal of well-being, which is the biology of the human nervous system, that we don't use very often. But when we start to learn about how the human nervous system works, it can actually change not only the way we sense ourselves on the inside, but also how we start to think differently. And I'm going to give you a few components of the model as I go through this today. But I want to tell you a little bit about what our vision is, because this is part of being here today, which is so exciting to me, is that we want to create resiliency-informed and trauma-informed individuals and communities. And what that means is there's a burgeoning field of neuroscience. And so I'd say that our models are a clinical application of this burgeoning field of neuroscience, that we've made things simple, accessible, so that even a child of 2.5, we have a little girl of 4 on a little video where she's teaching her brother, who's about 2, about the skills. And so I thought, oh my goodness, if a 4-year-old can teach a 2-year-old, because in the world that we live in, if we don't make things accessible, then we don't have the same chances to change the well-being that also changes our capacity to not only change what's happening within ourselves, our family, and the wider community, but it really, brings us at a disadvantage. And I was thinking yesterday, and this whole week, as we all know, it's an amazing experience being here, but when there's a pandemic like the Ebola virus, and hearing what the World Bank did was so inspiring, but then there's also what happens to the human suffering when you've lost your child, your mother, your brother. And that's the piece that I think that our community resiliency model can really play a very big part. And in Sierra Leone, in 2016, one of our collaborators is Loma Linda University. They went into Sierra Leone, and in the beginning they trained 40 people in our wellness skills, because part of this vision is also a commitment to bringing them to people, and that's capacity building. So we train community leaders to be trainers. And you don't have to have a mental health degree. You don't have to have any degree at all. You just have to be someone in the community that people respect. And that also have a desire to be a community resiliency model skills trainer. So from that 40, 20 people, I think it was 22, were selected to take the training, which was about 3 months later. And then of those 22 who were very excited about the model, they told us, they actually did some counting, that they had shared the model with over 800 family, friends, and community members. That's just from taking a 2-day training. And then of those people now, they're training other people within Sierra Leone, and Loma Linda is following 56 people of the second generation who were trained by the community resiliency model trainers. So the thing that's important about that is that we're doing research on, what do people look like before the training, what do they look like after, and what do these people that were trained by the community members in Rwanda look like. And we are seeing statistically significant reductions in depression, in anxiety, and in post-traumatic stress symptoms. And so that becomes very exciting for us in terms of how we scale this and we build capacity. So this is a very important part of our mission. And when we look at the community resiliency model, now I want to ask you this: in the places of the world that you come to, are there enough mental health practitioners to deal with as much trauma that is in your community? What do you think? I'm getting this. No, there isn't, not even in the United States, and we have lots of therapists and people that work very diligently towards mental health. So that's true all across the world, but like Chris was saying, there's some places that have 2 psychiatrists. So how possibly can we impact everyone who might need help? But what we've learned is whether you have a diagnosis of mild depression or whether you have a diagnosis of schizophrenia, that if you learn to stabilize your nervous system, that you can do better in managing your schizophrenia, in managing your depression, and in some cases, it may actually remove the effects of it. So what we're doing with the model is we're training trainers, capacity building. We're, of course, doing research, and that's what we're in the midst of. And this model grew out of, in California, we have a Mental Health Services Act. So we tax 1% of millionaires, and it goes into mental health innovation. I was fortunate enough to, with our organization, write a grant. And so we did we really field tested it between 2010 and 2013. If you go to our website, we have the executive summaries listed. But that's when we first saw, in doing the initial surveys, about the statistical significant reduction in depression and anxiety, but 2 other factors: a reduction in somatic symptoms that really are what lead people to go to the doctor, sometimes not knowing what they have, but also, and this was like, I didn't know this was going to come out of the research, a reduction in hostility indicators. And so we go, hostility? Well, why is that? Because when you access your well-being and you get into what we call the resilient zone, you have greater compassion for yourself, but you also have greater compassion for others. And instead of being stuck in states of what we call high arousal or the high zone, you're in a resilient zone. And so you're less likely then, that's what our theory is, to be violent. So that was very exciting to think of how that may impact. And we had 159 people in our research, our first research study in San Bernardino County. But as we started going, we first started this as a reaction to human-made and natural disasters, right? So then we're saying, wow, what if we train people on the ground preventively So they learn to manage their nervous system. And we were thinking, my colleague Mike Sapp, who's a psychologist, who's the associate executive director of TRI, we were talking last night after seeing Elizabeth Hausler get that award. And what we were talking about was that, what we do is we retrofit the human nervous system so that people learn how to be more resilient, so that no matter what happens to them later, they have greater resiliency to manage the windstorms and stresses that happen to all of us, but also the great disasters that we see happening, as we see here, the tragedies of the world. But if we have this front-loaded in our system, could that possibly change how we manage the aftermath of these things like the pandemic that we just saw in Sierra Leone? So the other thing, when there is a mental health system, we see that it would be wonderful in an ideal world that we had a triage system, that we have community leaders that are really boots on the ground, just like we saw last night in Liberia. And you have community, in fact, I got an email today from Sam Habimana. And Sam is a psychologist. He just finished his degree. He got trained in our model it's about a year and a half ago. And so there's 17 of them in Rwanda that are all wonderful community resiliency model skills trainers. So I was trying to get some numbers because I'm trying to keep up with what kind of capacity we're doing. And so he says, Elaine, we've trained 1,520 people. And then he said, but I want you to know that we have plans. We have to get more money, he said, because we think if we train 10,000 community resiliency model trainers, and they could be in 30 of the districts in Rwanda, we will change what's happening with the secondary traumatization. Then he tells me, you know that 45% of students now were born after the genocide, but they're having secondary trauma. So what I love about what he was saying to me was the excitement that he had from becoming a trainer, and he's created the Rwandan Resource and Grounding Organization for these 17 people. But that's the kind of capacity with the excitement when people see the model that they can imbue it with their own cultural lens, that then the model becomes their own. And I get wildly enthusiastic about that. So this is actually Sam's group in Rwanda, and you can barely see the pictures, but what they've done is they've taken the material and they've just done pictures of the skills. And so if you have a population that is low literacy, then there's so many different ways to teach the model to build resiliency. And this is a group of Nepalese that when we were in Nepal after the earthquake, we trained them to be trainers. Then the last day we go into the community and then they train people. And so there they were training a group of Tibetan nuns who had lost their monastery after the earthquake. So this whole idea of building capacity is so important. So we want to create this cadre of CRIM skills trainers who are informed about the psychobiology of trauma, the neurobiology of trauma, but most importantly, resiliency focused. And so this is a little bit different from many models. So instead of always talking about the problem, and we're not opposed to talking about the problem, people want to talk about the problem, but we'll say, well, can you tell me, if you'd like to, as little or as much as what has brought you here? And so sometimes people say, oh, you mean I don't have to tell my trauma story? Oh, no, you don't have to. But then we'll ask questions like, well, do you remember the moment that you knew you were going to survive? Oh, who's helping you the most? Or can you remember that moment when you got to this place, when you knew that there was shelter and there was food? Those are usually existential moments that creates in each person that we've asked those questions to, this sense of their own empowerment and resiliency, that it's very much a felt sense within their body that can be very empowering. And that's how we focus people into this aspect of resiliency. This is also from Rwanda, and this was during the commemoration, the memorial last year in April of the genocide. And Sam sent me this picture. He said, we usually work in community, Elaine, but this was one lady that was having a very difficult time. And so we had the opportunity to help her with the skills as she was feeling a lot of distress. So our individual goal is to widen the resilient zone for each person. Because if your resilient zone is widened, then that also impacts your family and your community. We want to reset the nervous system, so to bring it back into balance after a stressful or traumatic event. And most importantly, this is like the key of the model, is to have each one of us, including everybody in this room, be able to tell the difference between sensations of distress and well-being. Because the moment that that happens, then we can say, oh, there that thing is again. Every time I smell that aftershave because I was attacked by someone who had that aftershave, I can go, wait a second, I'm right here. I can feel the table, which is a form of grounding that brings me back to the present moment. Then I intercept the hijacking of the nervous system, and I can be in the present moment, and I can live my life. The amount of agency that that gives to individuals is so amazing and hopeful. And people often ask me, Elaine, how can you go to all these disasters? Because I, of course, am touched by the suffering, and I hope that always happens to me. But I'm also incredibly touched by the resiliency that I see, and also the resiliency that can be awakened when people start to pay attention to their well-being. The interventions are easy to learn. They're a set of 6 wellness skills. You don't have to talk about the past. If reading or writing is difficult, that's not a problem because you can learn how to track without knowing how to read or write. We have used this in so many different cultures now, and what's so exciting to me is we're translated in probably 15 different languages, and every time we do a training, there's always a lively discussion about what to call the key concepts. And so I don't know what those are, but they tell me what those are. And I said, it's just important that they make sense to you, because even the word resilience doesn't exist in every language. My mother was from El Salvador, and in Spanish, we call it la zona de bienestar, which is the zone of well-being. So we really give that agency over to the people that we train to imbue their cultural lens into the model. We can use it with different ages, women that are pregnant, can affect their babies if they're in their resilient zone. My father-in-law is 102 years old, and he was having some pain the other day, and I was using the skills with him. And he goes, gee, Elaine, I feel better. And so I think these are the kinds of things that are life skills. I think that's the other part of it. So we have educational materials. I already told you about iChill. But when I talk about the nervous system, and all over the world, I talk about the elegant design of the human nervous system, and that there are laws of nature, like we have a sunny day today in Oxford, but sometimes we have cloudy days here too. I guess a lot you have cloudy days. I live in California where it's sunny all the time almost. But in any event, there's also laws of nature within our nervous system. And we learn about those rhythms. We can also, as I said, learn to pay attention to the sensations of well-being. And when I go from, I'm done, okay. So I just want to really underscore that we talk about the neuroplasticity, which means the brain can change, and that gives people great hope that they can, in fact, learn that a lot of the symptoms they have are about the biology, not mental weakness. And that's another important aspect in terms of accessibility, because many people in the world are not psychologically oriented, but they want to learn wellness skills to feel better in their mind, body, and spirit, and I think that's what we've done. So this is the resilient zone, very simply. And then this is what happens when we get stuck in the higher low zone. And this is essentially the core of what we teach. So there you have it. And these are many people around the world. And my final quote, and I'm done. And this is not mine, but this comes from one of the South Africans that we trained last February. I think this is what Nelson Mandela meant by the Rainbow Nation. Learning how to stabilize the nervous system is equality and is beyond nations, culture, religion, and ethnicity. Thank you.
Thank
All
you.
right.
That's great. So were there just a few questions that people had before we ask you to get around the table that you've got there and begin to look at some of those questions as prompts to your discussion? But were there any questions of fact or any clarifications that you wanted of either model before we go forward? We'll take 5 minutes. Yeah, just wait a minute while we bring a microphone. Yeah, sorry, I should have reminded you.
While we're waiting for the mic, we're waiting for the microphone. I just want to say thank you to Patrick Kern for being here. His family has just invested in their family foundation to do a project in Hamburg, where we will be hopefully impacting many refugees coming from Syria and Afghanistan and Iraq. So thank you very much for being here, Pat.
Thank you for that. I just want to know how your model works in places where they're not affected by a trauma or any kind of disaster.
Well, so I'm going to ask you a question. Have any of you in this room ever had stress? Yeah, okay. So it affects all of us. So even if we haven't had a disaster, we can learn to track our nervous system because it can help us be better parents. I mean, I have 2 grown children now, but I remember when they were little, sometimes I was not in my resilient zone. I was in my high zone. Anybody else who are a parent ever been there? So I wish I would have known these things then. But we can learn to track and going, wait a second, she's only 4 years old. Let me put my hand on the table. Let me think about one of my resources or one of the other skills and come back into my resilient zone. So really, we really haven't found, too many places where this doesn't have some utility. The hardest thing about the model is that some people can't sense their body because they've had so much trauma. And if you can't sense your body, it's hard to be able to sense your resiliency. It doesn't mean it's impossible. It just means it takes more time and to be able to do that. And in our trainings, we help the newly minted CRIM skills trainers understand when people have had that kind of trauma where they can't sense their body.
Sure. My name is Sophie Edwards. I write as a reporter for DevX. I was really interested in what you were saying earlier about it being a lonely space, mental health, and obviously we heard from Jim Kim at the plenary talking about pandemic response and emergency response, and you made the point of what about after the response. And so I'd love to hear your thoughts about where you're at now in sort of getting mental health on that sort of discussion and where you think it might go and what needs to be done and what the international community should and can do.
Shall I jump in there?
Yeah, why don't you go ahead and give a response as well?
So the reference to loneliness was that literally in 99, 2000, when we started the organization, there were very few international NGOs who were working in the field. And so that was the first thing. The international global mental health movement has changed enormously in the period since 2000 to now. And I think that's probably best characterized by the presence of other NGOs. In fact, it'd be quite interesting to see those people who are running an organization in the field of mental health. Could you put up your hand just to... So there we are. You see, I feel less lonely already. I mean, that's quite a big difference. And if you'd asked the same question in the year 2000, it would have been A, much smaller numbers of people benefiting, and B, much smaller number of those organizations. So that's a very important thing. The Lancet, the well-known medical magazine, has produced a number of editions of rapportage on the international scene for global mental health. And they intend to bring one out in October of this year. And that, I think, is another example of the way in which the subject is being taken seriously, the evidence is being deepened, and so we are now in the context where we have an evidence-based subject, which has plenty of traction and plenty of thought behind it. The other thing is that there is now more training going on, and so we find that a number of the British universities and certainly a number of the US universities are now training in the field of global mental health as a subject in its own right, as well as all the medical and other related subjects, which of course make up the field. So in that sense, we are definitely in a different place.
I just want to add, and I really, my vision is to have people on the ground that are already there, so that people are not as dependent on NGOs when there is a disaster, so they have their own community-based. In our model would be the community resiliency model skills trainers that are already boots on the ground, already working within their community. We saw this in the Philippines. We were asked to come after Typhoon Yolanda, and I went many times. But the repercussions, of course, of Typhoon Yolanda are still there. But when we trained these trainers, we didn't realize that they would also use the model to deal with what's happening right now with all the deaths that are happening as a result of their new president and the killing of people with drug abuse problems. And so we see that there's now, it was so exciting because I had a Skype call with our community resiliency model skills trainers about, okay, how do they take the model and adapt it to this particular crisis? They're already there. So I think the more people that we can get trained in individual countries, the more that we can build capacity that increases mental health. And that's why, the simple little dosage of this little model that can do that. I think the other thing, and this is like, because I am from the United States, I get concerned sometimes because some of the research that's done through universities, and I'm, I did my internship at Stanford. Sometimes the research is not done in the field. It's done with university students regarding models that work. And it's very, very different to take a model that's been researched with university students and take it into the field after some disasters. And I mean, I totally agree that we need the evidence base, but I think we also need to be mindful of some of the Western approaches that may work very well for someone that lives in California, may not be the same degree of effectiveness if I take it to some places after a disaster that is not as psychologically oriented. Yes.
Thank you. Scott Haldeman, World Spine Care. We're in an interesting situation which is very similar. There's close interaction between pain, musculoskeletal pain, and psychiatric complaints is well described, and you brought it up a bit. We just submitted a paper on showing national statistics in the US showing there's a 5-fold increase in psychiatric complaints in people with spinal pain. So in our model of care, we have to have a very strong psychiatric component. There's a very strong linkage between psychiatric complaints and musculoskeletal complaints or pain complaints. So in our model, we ask every patient about yellow flags for psychosocial disease and try and deal with it. I was wondering whether in your models, you actually are trying to deal with the pain, because the opposite is true too. People with psychiatric complaints have a very high incidence of musculoskeletal pain. So do you actually address that component?
You're talking my language. I just love this because we've actually had a project over the last 4 years at Walter Reed Military Medical Center in their Wounded Warrior Chronic Pain Unit. And I asked one of the principals that keeps bringing me in to talk. I said, "Why do you keep having me here?" I'm just curious, because about the pain is that they have so many wonderful medications that help with pain management. But this is what one of the social workers did there, and I just want to tell this briefly. They have their little body where they have to mark where they experience the pain, and she's created an alternative body right next to that pain body. Where don't you feel pain? And so isn't that interesting? And so what we've seen there is when you bring your attention to where you don't feel pain, that actually starts to help restore the nervous system. I mean, if you really have, you have spinal, problems, it's not going to take away maybe the need for a fentanyl patch, for example. But to have another thing that you're using for yourself, because even with a fentanyl patch, as I'm sure you're well aware, is that you can still have spikes in your pain depending on what's happening in your life. So learning this model and again, bringing attention to the well-being is another way to expand more resources in your toolbox to be able to help with chronic pain. So we absolutely work with chronic pain. Thank you for that.
Just to very quickly add to what Elena is saying. I mean, where we are putting most of our attention and have been since the beginning is in the bringing together, the capacitation of large numbers of people. And I think it's true to say even today that the situation in many countries is very rough and ready. And so you may not get to that kind of relatively fine-tuned scenario that you would hope to achieve, having described the situation that you're working in. That said, a lot of the patients that we work with, particularly in the primary healthcare level, are presenting with somatic pain. And so there are obviously, to be simple, there are obviously other things going on. And if we can, and we have demonstrated this in a number of different countries now, if we can begin to offer treatment to people with somatic pain, then you start to clear the primary healthcare system, and that is an enormous benefit.
I'm Pascal de la Fragonnière, Cartier Charitable Foundation. If you could, I'd really appreciate if you could come back a little bit on the way you've measured the impact of your interventions and over which period of time.
Sure. Go ahead.
Okay, so when we first started, which is really the research project in San Bernardino, we used the Kellner Symptom Inventory, which was really, it's a 99 item inventory. It was too difficult. Then we developed a partnership with Loma Linda University, and the Associate Dean of Research, her name is Suzanne Montgomery. She's actually German, but now married an American. She lives in California. And she felt it was really important that we start looking at, because when we're measuring things biologically, it's different than measuring things psychologically. And so there's some instruments that cross and some that don't. So we've been using the Harvard Symptom Inventory, as well as there's a Connors assessment, and there's also one that we've used that measures resiliency factors. And I'd be happy, if you're interested, that I could link you to the actual ones we're using. We also try to use ones that have been tested with other languages, because we go to so many different places that sometimes the ones that we might be thinking about that are really good in English, have they been measured and tested in other languages? So those are some of the instruments that we've used.
In our case, we tend to be drawing from the economic and social development pantheon as much as from any kind of medical pantheon. So from our point of view, what's really important is that we found the people in the first place. Because don't forget that in many cases we're talking about, communities where it's not automatically evident. And we then do very simple measurements: who's been found, whether they're men, boys, girls, or women. And then we go from there and begin to describe the life circumstances, actually, which relate to the model that I've been talking about. So whether people are in livelihoods, for example, and if they are, what it is that they're doing, whether people are in treatment, and if they are, what is it they're being treated for, and so it goes on. And we'd be able to show you the model. And we collect all our data. There's a data collection system that we use right across the world. It all flows into Bangalore, and then we produce our data out of that. The data informatics is then used both by all of the programs that we dashboard for, and at the same time, we're now beginning to find other users of our data. For example, recently a paper published on return on investment by the WHO used some of that data to be able to do that. So happy to share it.
Jonathan, and then after that, I think we need to do our
thing.
Yes.
Yep, I think we do.
Jonathan Sandar from Peabody, social landlord in London. And that's really the context of my question, because much of what you've talked about is in developing countries with a sharp trauma event, perhaps. So in an urban environment where you have perhaps individuals who are very isolated, become very vulnerable, almost like a sort of a creeping trauma over a long period of time, one of the challenges we have is actually reaching out and engaging those individuals onto programs. So I think I'm getting to the question here. So where you have individuals who perhaps are very isolated, very locked into their own story, and are not open to being approached, have you found ways of actually being able to open the door and then to start to sort of work with them?
I think when people go into isolation following traumas, or when they've been living in that way for a long time, it's difficult. But I think that's where, when we think outside the box, how many different portals do we have to reach people? In our model, we've trained a lot of, for example, ministers, priests, rabbis, because sometimes access points are definitely not the mental health system, because they may be the primary care system if that person goes to a physician or to a nurse practitioner. So I think if we have different portals of knowledge about trying to help people also understand that as difficult as things has happened to them, there may also be other opportunities and hope, which is why we talk a lot about in a simple way, the neurobiology, about like neurons, brain cells that fire together, wire together, because that's, again, the hope of the nervous system is shifting that. But I think you have to have different people, boots on the ground, that may have access to this particular person that the mental health system may not. I think home visiting programs are wonderful if they're even involved in one, but those also can be far and in between, even in urban settings.
Just to complement what Elaine said, two different things. First of all, there is absolutely no doubt that one of the things that touches me most about working with people with serious mental illness is the loneliness that comes about, and quite often the inability to look after oneself on a daily basis. And so working in Detroit with Basic Needs US and Southwest Solutions, I was training a group of 50 men and women, different ages. About half of them were people who explained themselves as having a mental illness, and the other half are professional carers. We're working with them to form groups, self-help groups, not therapeutic groups, although it's less lonely to work in a group and therefore therapeutic. It was a joy to see how they could in fact manage a group and very rapidly got the ideas which were being transmitted to them. They came to the meeting in the first place by virtue of someone's boots on the ground bringing them in, and I think that was very important. I've begun to take an interest in urban development in the context of mental health, and since moving away from the daily management of basic needs, I'm still its founder, but we have my colleague right here in the front row, Adrienne Sell, who's the chief executive of Basic Needs. That's given me the time and space to think about these kinds of questions, actually. And we're forming an organization at the moment, of which I'm co-founder, called Mental Health Now, MH Now. And that's an organization that will look at cities, north and south, and will look at systems of cities in the context of mental health. And I think the other thing too that we will focus on is the de-siloing of the situation that mentally ill people find themselves, because the mental illness, in quotes, the illness bit is such a small part of the overall condition of being isolated and marginalized. And so a whole bunch of other groups, housing would be a very good example. Police would be another example. Often police are the first responders to incidents. Transport, etc., all need to have a much better understanding of this very large condition, 450 million and rising in the world, rising quite rapidly in cities, in fact. So we're bringing about a new collective action, which Basic Needs is a founding member of, and in fact, Sean, who's also sitting here, is another founding member of that organization. So we're bringing together this new initiative, which we'll be bringing to the world in due course.
I want to just add one thing, and that is one of the things that I get concerned about being a social worker as long as I have, and it just has to do with the word mental health, and is that it's really mind-body health. And somewhere along, I think it was Descartes said, "I think, therefore I am," and so then we became here. But it really is, I think, in terms of healing the human being, in terms of mind-body health, I would love to someday change the word mental health and expand it to mind-body health, because we are interconnected beings. We have this spinal cord that connects the head to the body, and that portal is often left out. And I think it also piggybacks on your question. I think when people think that they're, quote-unquote, a mental case, that's another way that they're prevented from getting care that may be really helpful for them, that's like offered through Basic Needs and other kinds of things that many of you are working on a daily basis. Okay, so one more question, and then we're going to go to our things.
We need to do
right?
it, otherwise we'll have no conversation.
Hi, my name is Kalia, and I'm from the Valcora. My name is Kalia. I'm from the Valcora Mental Health and Neurotech Initiative. And just going back to your idea of mental illness, I actually coined a term, mental injury, because the idea is that it is an injury that you could potentially heal from, but if you call it an illness, you think of it as something that's permanent, and it shouldn't be. But I had a question, because you had said that in certain instances, when people sort of start to deconnect from their body, the resilience model doesn't seem to work as well. Is that because they're going straight into fight or flight?
Because when we're teaching it, when we come in and we teach it in a dosage and we say, what do you notice inside? That's the key question. They'll say, oh, I don't notice anything. I mean, it usually tells me the person is really stuck in the low zone, in that place of really extreme depression, or that they've had something that we call a freeze response, that whatever's happened to them in their life has been so upheavaling for their nervous system that it's like, you don't do it out of volition. Mm-hmm. It happens automatically. It comes from your survival brain. So we try to help people understand then what may have happened to them, but then work with them outside of their body. Like we can say, is the room warm or cold? It kind of be a little indelicate. Do you know when you have to go use the toilet? Mm-hmm. That's a sensation. So we sometimes have to get the opening to the portal may be a little bit differently. It's not that it's impossible, but it makes it more difficult because, and this is like a more complex discussion we could have afterwards, is sometimes the sensations of well-being are coupled with the sensations of distress. And so that's what makes it a little bit more difficult.
Well, my question was more specifically, they've just come up with 2 new terms. One is called human devastation syndrome, which they've seen in Syria, for example, children who have seen, massive devastation from war. But then also now they have a new one, which is resignation syndrome, which is it's a coin that they termed in Sweden for the sort of when a lot of the refugees were told they were being deported, some of them just became almost comatose.
Yes.
And I'm wondering, do you ever use things like proprapanol or holotropic breath work, other things to kind of get them back and cut that fight or flight?
Right, and I think that if you have the opportunity to have medications that may help, certainly I would not be opposed to that. The sadness is that that's not available to everyone, right? But I think that if there are ways to waken up the nervous system. See, all those names that you just said, I would say, well, what are you noticing on the inside? I would have a hunch from how they're being described is that they become disconnected, that they go into a state of a lack of sensation, which is connected to your vagus nerve. It's called a dorsal dive. It's more complicated, but anyway.
Right.
I would love to talk to you more about it later. Yes.
Should we crack on?
Yes, let's crack on.
Thank you.
All right. We have questions that Chris and I came up with.
We did.
Because and now we're, so how would you like to do this? I think we should get people. Yes, right.
Let's pack the table so that you've got as good a conversation as possible. So
can we have you 3
got 2
maybe
here
add,
and 3 here.
So we'll have, and so there's 4 questions, and I think my inclination is, why don't you pick the ones that you want to work on?
Yeah,
I mean,
exactly.
maybe you have time for 1 question, so you can see there's 4. Pick the one that you want to work in, and then brainstorm for about
15?
I don't think that's, no, what time are we done?
Where are we?
What
time
are we done? You said you gave...
Sure.
So we'll give you
10 minutes.
10 minutes. We're going to give you 10 minutes. 10 minutes to have a lively discussion. Okay, we're so excited that you guys are talking so lively. We wish we had another hour. We could stay all day. All right, let's get going. And so what we'd like to do is we'll go from table to table, and we'll ask each of you to say which question you chose, and then let us know the discussion, what kinds of things that you came up in your discussion. So because this table is so lively, right in front, and they're so excited, and I have no idea who their spokesperson is. Who's your spokesperson?
Sean, well
done.
done.
Sean. All right, Sean, let's go. All right, Sean, so which question did you...
Well, we did number 2, and we kind of went around, because we're global. We have Myanmar and Pakistan and the UK and India and, well, globally. We all have different challenges, but we're not going to really tell you what we answered. What we really wanted to say is somewhat of, and forgive the pun, the insanity that we're really even talking about mental health. That on the agenda, we're talking about mental health at the Skoll World Forum, because if there was an agenda item that we're talking about physical health at the Skoll World Forum, we'd be laughed out of the room because it's such a broad topic. But we all allow ourselves to just talk about mental health as if it's a narrow topic that you can really talk about, because it is so broad. Yes. And that we really have to stop ourselves from just allowing us to talk about mental health as if it's just 1 or 2 illnesses. It is so broad, but we allow ourselves to pigeonhole. And that alone, we just thought is just...
So did you come up with any new terminology that we could, this is Skoll.
No,
and
we
can do anything.
Like Kalia was mentioning, it's a terminology issue about just, mental illness, mental injury, mental health. It's about, we have to allow ourselves to just open it up more. And we allow everybody to pigeonhole us. Like Adrian and I were saying, we do mental health in the developing world. And even that alone is like if we said, we do physical health in the developing world, people would laugh us out of the room, because that's just so broad. It's as if we don't know what we're doing. So we don't have an answer, because you only gave us like 5 minutes.
I know, but this is just the beginning. We're going to have more discussion.
5 more minutes to get the answer.
Yeah, that's right. 5 more minutes to get the answer. All right.
I ended up holding them.
So second group.
Yeah. Just while you're getting to there, can I just make a comment on that?
All right.
I mean, it's just worth remembering that although they've been incredibly gracious about it, let me be very clear, it's taken Elaine and me several months to get this agenda item.
That's right.
And so whilst we were talking a little euphorically about the state of the nation being better than it was, that isn't to say that it's great. And so we all need to make sure that and I absolutely take your point, John. We all need to make sure that the right agenda comes onto the this kind of forum. And we've got to keep working at it. The other thing we haven't talked about is the financing of this field,
Yes.
which is absolutely disastrous. So let's see what the other tables have.
Yes.
Derek Brown.
Hi, Derek.
Hi, Derek.
Good to
Thank you for
good
being
to be
the
here.
spokesperson for that.
Sure.
table.
I mean, if we had 11 minutes, we would have solved it. But we were talking about a number of cultures and contexts: Germany, United States, Lebanon, and its Syrian refugees. So, but some of the things we talked about more generally is obviously the difficulty in even acknowledging treatment across cultures, whether it's German folks or refugees in Germany from Afghanistan, that there's a tremendous stigma that is still attached, as we all know. One of the interesting things that was brought up in our group is that people are now trying to rename things, as we were talking about at the end of your presentation, but PTSD, I guess, is now being renamed or relabeled somehow, one of our participants was saying. We had also mentioned that spokespeople in public who are figures of respect, acknowledging, I brought up the incidents of the First Lady in the United States. Gerald Ford's wife was the first person to acknowledge substance abuse, and that became a real marker, but we haven't had enough of that. Obviously, a shortage of staff, lack of access. This morning, I had breakfast with Bunker Roy, who is the founder of the Barefoot movement, and certainly your model seemed to relate to that. And I would say, and sexual violence was something we began to talk about at the very end, and the re-traumatization that happens in the reporting of that, which communities in the United States are beginning to address, but certainly not consistently across the board. And so we really have to think carefully about that. And there are a lot of problems. There are two possible positive things we came up with.
And okay, that's good.
That's great.
Yes,
Thank you very much. Yeah.
So let's go to the third table for making sure that we get
Your
enough.
microphone is there.
Yes.
Okay, so Kalia, and we had a very lively discussion that kind of ran the gamut, which gets to your point that mental health is so broad that it's very hard to sort of answer all the questions at once. We talked a little bit about how to get away from the stigma of it just by a relabeling that, if you say to somebody, it's a problem with your back pain, but this Prozac will help, and if you go to a community center, then this will help with your meditation, but actually it's being in a part of a community that's more important than being in a meditation group. That kind of deals with the other section of it, which was really social isolation. How do you get people when they are really in mental distress to come out and to be part of the world again? Even a mention that you made, Ned, about when you give people sanitation, then suddenly they have no watering hole to go to, and they have no community anymore. They're stuck in their houses. So how do you create? I mean, I think part of it that really came up was the power of community and how you can really, in order to build resilience, you need to build these networks, and you need to make people feel comfortable with whatever it is that's going on with them, even if it means sort of doing a little bit of a bait and switch in how you speak of it. There was a lot of interest in sort of what do you do post-conflict? How do you help women in those situations, men in those situations? How do you access them, and how do you make them understand what you can do to help them? And we talked about happiness. That actually, that's part of the coin is mental wellness. And how can you promote happiness in these situations? And was brought up that there's other types of innovations out there in terms of neurotech, where you can kind of use a phone and Headspace and whatever it is, apps that can help you do that. Additionally, there's positive psychology. And then I mentioned sort of my interest, which is really looking at mental health innovations that use new protocols. So really doing tactical interventions post-conflict using either propranolol or psychedelics, which can in basically 1 week do what usually takes several years to do. And could this be something appropriate in the case where you're having trauma that is becomes embedded in the body, but then also trauma in the community that then repeats itself generation after generation because it's so hard to reach everyone. So that, we didn't answer any of the questions,
We noticed.
but that's a summary of what we talked about, and it was really interesting.
That's the wonder of bringing everyone together. Are we almost done with our time? Do we have 5 minutes or so?
Can we just wrap up?
We have 3 minutes, okay. So I guess we each get a minute.
We each get a minute, that's plenty.
So do I go first or you?
Yeah.
Okay.
Oh, that's fine.
So I love the conversation. I think we need to continue the conversation. I want to say just one thing about one of the things I've learned is that, to kind of piggyback off some of you said, there's many, many people that wouldn't take a medication because it's just not in their culture to do that. And so, but we have within all of us the ability to come back to our better self if we pay attention to this body of ours. And every thought, feeling, belief has a corresponding sensation. And when we talk about what's happy, what is happiness for each one of you? It would be different for all of us. But when we sense it in our body, the nervous system would be pretty similar in terms of how we would respond to it. So when I ask people, what helps you get through in China after the Sichuan awful earthquake that happened there, and they would have an effigy of Buddha around their neck, they would touch it, and they would take a breath, and they'd say the teachings of Buddha. In Haiti after the earthquake, what helps you get through? I got Jesus right here in my heart. A deep breath. The same breath, but with a different roadway there. And so that's one of the things I think to also think about. As much as we love the technology and what we're developing, sometimes the technology is not there. I think we need menu options. We need a number of different things. And if anybody tells you one thing is the right answer, run to the hills. That's my final word.
So before I run to the hills.
Okay, before you run to the hills.
Just a couple of things. First of all, the fact that you didn't answer the questions is very, very stimulating from my point of view, because you had better things to talk about, which is great. And the most important thing is that this is a room, I now sense, which has disruptors in it, which is important, because this is a field which, as you have said in your own various ways, needs new ways of thinking. It needs new approaches. We need to demedicalize it in the sense of take it away from the medical profession, and we need to make sure that lots of other people get an opportunity to work in it. So disruption is really important. So I would encourage those of you who are kind of half in and half out to go the whole length and actually start to work in this field as people, as social entrepreneurs. Who knows, you may get to be like me, an awardee in future years, and why not? It was useful money when it came. But I left. But the fact of the matter is that this is a field which is wide open, and really it's inviting you to come in and work in it. So thank you ever so much for coming today.
Thank you so much. Thank you.